Okay, so I think the last people have come in now. You're all very welcome to Liverpool Medical Institution. For those of you who haven't been before, you'll maybe know a little bit about the history, that this was originally 1779, I think. There was a journal club, and the doctors got together and said, oh, actually, we need a place for it. And so this place was built 1836 and has continued really as a place of learning ever since. And do take a bit of time to have a look around the foyer and have a look around after the meeting. Not now, not now. My name is Andrew Weeks. I'm president for this year, and I've had the joy, I guess, of putting together a program of my favourite speakers and people I think would be really interesting, which is rather nice. Somebody I got in the diary pretty early was Benjamin Black, who's come up from London, where he works as a consultant at Whittington Hospital. But from this conversation point of view, is lead advisor for Medicine Sans Frontières. And it's very nice to see the friends of MSF. Thank you very much for supporting us this evening. So it's great to have him here. People have said, oh, talking about maternity during a humanitarian crisis. Oh, he's talking about the NHS. How wonderful. But I think that's not the case. He's going to be majoring really on his special interest, which is humanitarian settings. And maybe you'll also mention that his excellent book, he's an award-winning author. Belly Woman is a fascinating read. It's a page turner, but it's also quite a harrowing read as well, because I think you feel yourself in that situation. You think, oh my goodness, what on earth would I do? So it's a bit like watching Alex Honnold climb whatever tower it is in Taiwan. You're sort of gripping your seat, thinking, I'm glad I wasn't the one who was there in that moment. But it's a fascinating read nevertheless. So I'm going to stop waffling. I'm going to hand over to Benjamin. Thank you so much for coming up and look forward to hearing what you've got to say.
Great. Well, thank you very much for having me. Thanks for making it here in this weather. I'm sure it's much more pleasant to stay at home. Andrew asked me to talk about what is good maternity care during humanitarian crises. And I thought a little bit about what I wanted to say today. And I thought the best approach would be to take a more personal journey and think, what do I think? What does good look like from the experiences I've had, but also to use that as a way to open up a conversation that hopefully we can have later on after my presentation. A few things just to mention before I dive in. I am talking about humanitarian crises, which are the most extreme situations that humans can find themselves in, which means some of what I talk about can be upsetting or distressing. I am going to make references to sexual violence, and it's important that people listening are aware of that. And as you can see, I usually use my slides just as pictures and as photographs. Most of the photos are not mine. Most of them are from professional humanitarian photographers, such as this one from Isabelle Courtier. But any photos, whether they're from myself or from a professional, if there are identifiable faces, it means that there's been consent given expressly for the use of those images in this presentation. So maybe just to start, when we talk about humanitarian settings, maybe not this audience, because I think we're slightly within the same echo chamber, but a wider audience might question, why dedicate a talk to maternity care in humanitarian crises? When there's a humanitarian emergency, by its definition, everything is in crisis. The under 5 mortality rate skyrockets, malnutrition rates go through the roof. We see disease outbreaks. We see high numbers of casualties from violent conflict. And maternal mortality, maternal deaths, although they are more common in a humanitarian crisis, they still are relatively infrequent in comparison to some of these other types of mortality and crisis findings that I'm mentioning. But what I would like to impart to you through my presentation is why it's really vital that in every humanitarian crisis, we take special consideration of maternity care and look specifically at maternal mortality to see what we can learn from it to try to reach something that comes close to good. Okay. Yeah. So what I'm going to cover during the course of this presentation, I want to define a little bit about what actually is humanitarian. What do we mean by that when we talk about a humanitarian crisis or a humanitarian setting? I want to focus on how we learn from maternal deaths and how that can help us reach some sort of understanding on what good maternity care might look like. I want to focus on respect and dignity during humanitarian crises, particularly for maternity care, and then to look at where maternity care fits in with the broader picture of sexual and reproductive health and rights. And then lastly, to look at the road ahead and what the future might look like. And as I said, hopefully that will draw us together to some sorts of conclusions and opening a conversation. The clicker might be a bit better, is it? Yeah, okay. So towards the end of 2025, there were 2 billion people living in fragile settings, which could be one way that you define a humanitarian crisis, and 300 million people around the world who required emergency humanitarian assistance. And of those, 1/4 are women and girls of reproductive age. But as I said, humanitarian can mean different things to different people. And I wanted to explore a little bit as trying to understand what is the question that was put to me. What does good look like in a humanitarian crisis? What exactly do we mean by that? So we can think about it as fragile and conflict-affected settings. We could consider it as countries or contexts where there's already a plan in place from the Office for the Coordination of Humanitarian Assistance, or we can consider it whether or not it depends on what the level of suffering is. Do we define our humanitarian settings based on the degree of suffering, the degree of mortality? We also need to think about which humanitarian settings do we really know about, which ones do we focus on, and the geopolitical context within that, because the ones that we hear the most about might not necessarily be the ones with the greatest degree of suffering and the greatest degree of mortality. We also need to think a little bit about when does a humanitarian crisis start? When does it end? How does it change during the course of that journey? For example, we could take South Sudan, which has been a protracted humanitarian crisis for decades, but at the moment is disintegrating back into active civil conflict, and so is very much an acute on chronic crisis. Or we could take the example of Sudan, which over the last 2 years has been arguably the largest humanitarian crisis in the world. And yet within it, we see pockets of other humanitarian crises developing within it, so emergencies within emergencies. For example, hepatitis E outbreaks or cholera outbreaks, or pockets of famine within the broader picture of this, very destabilized civil conflict. And of course, we can think about humanitarian crises in terms of displacement, disease outbreaks, disaster, destruction. From my perspective, whatever definition we use and wherever we draw the line of where the crisis starts or where the crisis ends, we need to be incorporating maternity care, and we need to be incorporating sexual and reproductive health and rights. And that's because we know that in every single type of crisis and through all stages of that crisis, women and girls, especially pregnant women and girls, are going to be particularly vulnerable. And through the nature of a humanitarian crisis, as we see the normal coping mechanisms that the population might have start to disappear or change, and the resilience levels start to be affected, we know that those vulnerabilities will increase. The other aspect that I wanted to draw on when I think about humanitarian crises and sort of this terminology of humanitarian and maternity care is what I'd consider sort of the two sides of the coin, which is what happens for pregnant women inside a humanitarian crisis because they happen to be living in the place where that crisis is happening, and what happens for pregnant women specifically because of the type of crisis that it is. And an example of that would be in a disease outbreak. So say, for example, in the Ebola epidemic in West Africa, for a pregnant woman or girl who was happening to live in West Africa when the Ebola epidemic happened, there was a steep increase in maternal mortality and morbidity. And this was because the health centers started to close down, healthcare workers feared coming to work, the economy started to go downwards, people couldn't afford to get to health centers, schools started to close, unintended pregnancies went up. So this was all sort of a pocket of the broader context. But then you had the very specifics of the crisis, which was, what about pregnant women and girls who become infected with Ebola? What about pregnant women and girls who end up being put into Ebola treatment centers? And what happened to them? And the reason why I draw on this is because in every type of crisis, we need to sort of take a step back and ask ourselves, how is this crisis affecting women and girls differently to men and boys? What is it in this crisis that might have specific consequences for pregnant women? And these are questions that ideally we need to be asking ourselves in the very beginning of the crisis, or even better, before it's even happened, if it's in an area that we know is at risk of complications. Am I pointing in the wrong
Maybe just
way?
try the forward.
Yeah, this makes slightly better. Okay. Right. So going back to what do we consider to be good care in a humanitarian setting, part of what I thought about when I was pulling this presentation together were examples for me of what I might consider to be good care. And so I want to give you the example of Nayamal. She's a 40-year-old woman living in South Sudan. And this is a patient that I became aware of about a year ago. Nayamal was in her 6th pregnancy. She had 3 living children. She lived in a remote part of South Sudan, and she did not have any antenatal care during that pregnancy, which was very common within this part of South Sudan. She went into labor out in the community with a traditional birth attendant and expected to have a normal delivery. Parts of the reasons why she hadn't had antenatal care, parts of the reasons why she hadn't made it to a health center were because the areas that she was in were both very insecure, and also there was flooding. It was an area that's also been affected by environmental degradation. In this moment, this pregnancy, the baby didn't birth in the way that her others had. And she labored at home for 24 hours, pushing and pushing and pushing, and the baby didn't come. She was able to get a boat, and then she was able to walk until she reached the nearest health facility, which was what we would call a basic obstetric and newborn care center, where there were midwives that were able to assess and to help her to give birth. She was found to be fully dilated. They attempted an assisted vaginal delivery with a vacuum cup. So this was a facility that had staff. It was a facility that had equipment. It was a facility that had drugs. But the vacuum assisted delivery did not work. This wasn't a facility that had access to an operating theatre. And the nearest operating theatre was so far away that you could only really get to it with a flight. But for this facility, they also had internet and a satellite phone. So they were able to call for assistance and to say, we have a patient, she's in an extreme situation, we've done what we can here. We need to refer her onwards to somewhere else. But because there was flooding, the flight was not able to land. And so they were able to then call through a telemedicine service for expert advice and talk through what can they do to keep Naimal alive whilst waiting to organize a flight to get her to the next level of healthcare. And a day later, they were able to get the flight, they were able to get onto the landing strip. They were able to fly Naimal to another hospital within South Sudan, where she was then able to have surgery. She was found to have a ruptured uterus. She had a hysterectomy. She survived, and she went back home. For me, this was an example of something coming close to trying to provide good maternity care within a humanitarian setting. It's not perfect, but it's good. I want to tell you about someone else, though. And this is someone from last week. I can't give you her name, but I can tell you that she was 26 years old. She was also in South Sudan, in the same area that Naimal came from. Her first baby, she took 2 days to birth. It was a long, difficult labor. She wasn't able to reach a health facility, and she had a stillbirth. This was her second pregnancy. She came to a health facility in labor. She got, again, to fully dilated, but the baby wasn't coming easily. But the baby was alive, and the same process that we went with Naimal started, looking to find out how can she be referred. But at this moment, the area that she was in got raided by militant groups. The clinic got looted, and all the healthcare workers, along with the patient, had to flee into the bush. And we don't know what happened to her. And the reason why I wanted to sort of give these two stories is to say that part of the challenge that we face with trying to provide good maternity care in a humanitarian setting is also realizing that there is unpredictability to humanitarian settings. They are often moments of chaos, and we have to do the best we can with the resources that we have. But sometimes that can fall really short of what we want to consider to be good. And it can quite often fall outside of our control. I said that I want to focus on a little bit on maternal death. And there's a reason why I want to talk specifically about maternal death. And that's because to get close to understanding what good might look like, we need to understand, like with Naimal and like with the other patient from last week, what the journeys that these patients go on, either to have a safe birth or a birth that results in a death. Because by learning from their journeys, we can start to understand how we can also make improvements. So at the beginning, I spoke a little bit, I mentioned about sort of maternal deaths being relatively rare events in the picture of the other types of mortalities and deaths that we see within humanitarian settings, and why I think it's so important that we focus on them. And that's because for each maternal death, the impact that it has across the family, across the society is huge. And the way that I would consider the maternal deaths is that it's like a drip of water landing in a pool and the ripples that spread out across. We know that when a woman dies giving birth, it's not just the tragedy of the loss of her life. We know that it also has a significant impact for surviving children in Ethiopia. If a woman dies giving birth and the baby survives, there's a 46 times greater chance that baby's going to die in the first few months of its life than if the mother had survived. We know that for existing and surviving female children, they're much more likely to be taken out of school, much more likely to be married early, and much more likely to have adolescent pregnancy and repeat the cycle of severe maternity complications. What we see, and we see this quite often in humanitarian crises as maternal mortality goes up, is that it tells us a lot about what's happening within the society. It tells us about decisions that are being made, about where resources go, about what's considered through social, political, economic decisions to be prioritized. But we know that when we start to see greater harm and greater death within the pregnant population, it's a warning bell of larger consequences happening through society. And I'm sure you've heard the phrase "the canary in the coal mine," but this is often how it would be described. And 60% of maternal deaths do happen within humanitarian crises if we're defining them as fragile and conflict affected. So what I thought might be useful is to take a couple of examples of more recent humanitarian crises where we've really looked carefully at the maternal deaths to see whether or not that can help us work towards a good type of maternity care within humanitarian crises. So the first context that I wanted to talk about was Tigray. Tigray is an area of northwest Ethiopia. The population is just over 7 million. And in November 2020, a civil war broke out between the Tigrayan forces and the wider Ethiopian army. And then Eritrea also sort of got pulled into this conflict. It was a massive humanitarian crisis. It didn't get a huge amount of attention in the media, but all sides committed war crimes. There were mass extrajudicial killings of civilians. There was extreme systematic sexual violence, some of the worst that we've ever seen. And the numbers that are thought to have died is somewhere between 162,000 to 600,000, which is, there's a reason why it's such a wide estimate. And this is part of the difficulties that we have within humanitarian crises of understanding mortality. So mass displacement and also mass food insecurity. What did this conflict mean for maternal health? Well, prior to the conflict, Ethiopia was already one of 4 countries that report over 10,000 maternal deaths each year. That's partly based on the size of the population. Having said that, it had made significant strides in improving maternal health within the country and reducing maternal mortality. And Tigray was one of the regions which had really advanced in this area. As a result of the conflict, 83% of the health facilities became unable to provide maternity care that had prior to the conflict been providing maternity care. And maternal deaths were found to have increased by 5-fold. On the border with Eritrea, where the conflict was the worst, the maternal mortality increased by 18-fold as a result of the conflict, with newborn deaths also increasing 4-fold. It rolled back progress by about 20 years. But this is what we know now. It wasn't what we knew then. And actually, we missed how severe the maternal mortality was during the response. We found out later as we started opening vaccination clinics and responses to malnutrition. There was very severe malnutrition. And what we started seeing was babies being brought to the clinics without their mothers. And when we started asking, we understood that the maternal mortality had been staggeringly high, but had been largely hidden. And essentially, we had missed the canary in the coal mine. And so we took a step back and looked at how it was that we could have missed this. And part of it is that we don't actively look for it. When we have a humanitarian crisis, although we have many tools to look for mortality, maternal mortality is not typically part of that. Partly because there aren't as many, so it's more difficult to capture in a small space of time compared to under 5 mortalities or conflict-related mortalities, but also because the WHO advises against it in the immediate part of a humanitarian crisis. So as a result, we developed a rapid maternal death surveillance and response tool to try to better understand how many women are dying, what were they dying from, what were the underlying causes, and what could we learn to improve the maternity care that we were providing within what was a very severe humanitarian crisis. And so Tigray was the first time that we used this approach. And we started in one hospital, and in the first 2 months, which was our trial, what we found was that there were 8 maternal deaths in those first 2 months. What was really significant was that the majority of those maternal deaths, 5 out of the 8, were not from any of the leading causes of maternal mortality that you would typically hear about. They weren't from PPH, they weren't from eclampsia, they weren't from sepsis. They were from women walking into the hospital or coming to the hospital, still pregnant, with severe anemia and dying from congestive cardiac failure. And this was part of the bigger picture of what was happening within Tigray as a result of the conflict. But it had a very significant impact on the overall humanitarian response and the strategy that we had. And as a result of doing the surveillance, we were able to change the way we were responding. This meant that we opened a medical ward dedicated to antenatal women, employed midwives to work on that ward. We rehabilitated the blood bank. You can see how the blood bank looked. This was the centralized blood service. We rehabilitated the blood bank to ensure there was access to safe blood transfusion. And we worked on different ways that we could treat the anemia. We also ensured a way that women who were admitted into the antenatal ward could continue to stay in or close to the hospital until the time of birth. And in the first 3 months after making these changes, we had 92 women admitted into the ward. All of them had severe anemia. That means less than hemoglobin of 7. And over 50% had hemoglobins of less than 4, which we considered to be a near miss, because our feeling was, had they delivered away from the hospital and had bleeding, that their risk of significant harm or death would have been very high. And of those women, all of them gave birth safely and none of them died. This implementation continues. It continues today, but it's also moved into the community, looking at ways that we can counter anemia within the community. And to say that the women that we were seeing in the hospital weren't dying from PPH, that didn't mean that they weren't dying from PPH in the community. It's just that they were never making it to the hospital in time. They were dying on the roadside. They were dying back at home. And so we were able to start programs that were centered on getting closer to the community and trying to reduce the impacts of anemia or help them find ways to get to the hospital or be near to a clinic. And this process has also been now adopted into the Ethiopian national maternal death surveillance mechanisms. So what I'm describing is something called maternal and perinatal death surveillance and response. And this is taken up by most countries in the world. Most countries in the world, it's, reviewing, recognizing, learning, and responding to maternal and perinatal deaths, as well as near misses, and trying to improve the care that we provide. Doing this in any context is difficult. It takes a lot of work, a lot of effort, a lot of investment to keep it going. Doing it within a humanitarian crisis had previously been considered to be near impossible, which is why the guidance had been, don't do it. But what we're finding is that by doing this right from the very outset of a humanitarian response, we can tailor our responses within what are very limited resource settings where we're struggling to get staff in, we're struggling to get medicines in. We can't do everything. And as I've mentioned, there's many competing priorities. It's not just maternal mortality we're thinking about, but it's everything. Everything is in crisis. That we can use this to make an argument for what will be most valuable in saving the lives of pregnant women and girls during that crisis. And the second example of this that I wanted to take you through was Sudan. So, as I'm sure many of you know, there's been a devastating civil war in Sudan, started in April 2023. It is considered the largest humanitarian crisis in the world today. There are over 9 million internally displaced people in Sudan, and it's estimated that there are 30 million people in the need of humanitarian assistance, of which 24.6 million are facing acute hunger, and 2 million are thought to be in or at risk of famine. And this is again very relevant as well for our maternal health response and the impact that it has on pregnant women and girls. As I mentioned earlier, there are also repeated disease outbreaks within Sudan, cholera, hepatitis E. I mentioned hepatitis E because the maternal mortality in the hepatitis E outbreaks touches 50%. And this is essentially a war that is between two armies, but it's being placed onto the civilian population. The way that it's fought is through destroying the civilian infrastructure in different parts of the country. It is a complex conflict with many shifting front lines, and that has also really had an impact on the way that we are able to respond to the conflict. When we first got access into Sudan, it was in the east of the country, and it was in the early part of the conflict. And we were invited to a maternity hospital, a large maternity hospital that delivered over 2,000 babies every month. And in the month that we arrived, what we found was that over 50 women died giving birth in this one hospital. And so we, again, implemented a system to rapidly start reviewing the notes and investigating what happened with all of these deaths. What was the story? What was the journey that these women and girls went on that led to this devastating outcome? And what we found in this situation was that it was not a clinical cause. It wasn't anemia. It wasn't PPH. It was a systematic issue. All the women and girls came into the hospital through the same emergency department, where they were often seen by general physicians. So there was often a delay in diagnosis or a misdiagnosis, and there wasn't access to emergency treatments within the emergency department. And so again, this changed the strategy within the response, and the emphasis moved towards having a dedicated triage system, having maternity emergency boxes, and training within the emergency department. The birth rate remained the same, 2,000, just over 2,000 births a month, but the mortality dropped to about 2 to 3 maternal deaths a month. Still too high. We know that nearly all maternal deaths are preventable, but a significant difference. But as the front lines shifted, we had to leave that part of Sudan. We weren't able to continue and handed over. When I say we, I mean MSF. We handed over to the local providers to continue what we had started. And this happened at a time when the conflict itself was shifting into Darfur, which became the epicenter of the conflict, and that would have been around October. In Darfur, we started working in 2 hospitals and in 3 IDP camps, internally displaced person camps. And again, we started looking at death rates, maternal mortality, something which we had not previously been doing on a regular basis. In the space of 8 months, we, and this is just as I said, just 2 hospitals and 3 not very large IDP camps. There were 114 maternal deaths. Just to put that in perspective, that's more maternal deaths than you would see in most Western European countries in a year. What we found in this instance, even though it was in the same region, was again different. The leading causes for maternal deaths was sepsis. And so, particularly in the hospitals. And so this tailored our response. This, again, if I was to take a step back and say, how can we, with the resources that we have, which at the time were very limited, there was a lot of difficulty getting medicines, getting people, getting commodities into Sudan, and particularly into Darfur. What can we do to try to improve the maternity care? And so we focused on how can we reduce sepsis. And we did something which we would almost never do in an emergency response, and that was to rehabilitate the infrastructure of the hospital, because we identified that one of the root causes around the sepsis was in the operating theatre, which had been badly damaged, and also in the sterilisation system for the instruments. And so we did an infrastructural rehabilitation whilst there was active fighting happening around and conflict happening. And this, again, greatly reduced the amount of sepsis. We also teamed up with local providers, the Sudanese Family Planning Association, to work more into the community and to set up women's health clinics that not only were able to provide antenatal, postnatal care, uncomplicated deliveries, but were also able to identify those women who needed to be referred into a hospital so they could reach in a timely manner, as the vast majority of maternal deaths that we saw in the hospital were from women arriving far too late. And we also were able to then incorporate into that responses to sexual violence, contraception, and safe abortion care. So from our perspective, what we found was that by doing these rapid maternal death surveillance and responses, even in very volatile and resource-restricted settings, we were able to identify the ways that we could improve maternity care and tailor our response when we could not do everything, when we were really, really outstretched. We also found that we could use it as strong advocacy, both internally within the humanitarian infrastructure, to emphasize the need to focus on maternal health care, which often is overlooked, but also externally. And finding some of these reports ended up being presented at the levels of the UN, at the Houses of Parliament, but also within other larger humanitarian settings. The QR code takes you to one of those advocacy reports. So I have been, how am I doing for time, Andrew? Am I okay? Yeah.
5 minutes.
Okay. So I've really been focusing on maternal health, and I've been talking about pregnant women and girls that might come to harm and the response that we have for them. But it wouldn't be realistic to only talk about that, because that is one part of the picture of sexual and reproductive health and rights within humanitarian settings. And the international standard, in fact, it's considered a mandatory international standard, is that this very busy slide is implemented within the first 48 hours of the onset of any humanitarian crisis. Now, this is called the minimum initial services package. And I hope you can tell from seeing it, but I can certainly tell you from experience, it's anything but minimum. It is a lot of work. It is a lot to do. And when you think about the source of sex that I'm talking about, it becomes near impossible. And actually, this has been around for 25 years. And there was a paper released just earlier this week that looked at 64 countries over the last 4 years and showed that although 95% of these countries had this built into their emergency response, only 40% actually managed to get close to doing it. And that, to be honest, that was more than I had expected. But, you know, when we think about what should good maternity care look like in a humanitarian crisis, it actually does need to have all the pieces of the puzzle built into it. We know that, you know, sexual violence is going to increase, access to contraception is going to decrease, increase in transmission of HIV or inability to access treatment for HIV. We know that the number of unintended pregnancies is going to increase, and women and girls are going to seek abortions. And so without safe abortion care, we are going to see, again, more harm, more maternal mortality. And so to get good, we do need to find a way to somehow pull these pieces in whatever way that we can. But, you know, I've been talking till now about what I might see or reflect on how we can have good maternity care. But really, it shouldn't be me who's saying what is good maternity care in a humanitarian crisis. It should be the women and girls who are living in those situations. And what I think about is, you know, what I thought about when I was putting this presentation together is what might those women and girls think if we were to ask them what is good maternity care. And one of the things that I think would come up high on the list is having dignity, having respect, and having places that they feel safe and that they can reach. And an example that I would like to give is from the maternity response that we implemented post-Ebola in West Africa. So we put together a really nice maternal health. In fact, we covered pretty much all the elements of the MISP that I just showed you. It was really nice. And women weren't coming. Women and girls weren't coming. Now, the maternal mortality at that time in Sierra Leone was the highest in the world. And yet we weren't seeing as many women and girls coming as we thought we would. So we started an ambulance service. We thought, well, let's help them get to us. So we had an ambulance service, and still we found that they weren't coming. So we went out into the community and we started holding focus group discussions and listening to what they had to tell us. And what they told us was, because there were cases of, you know, a woman having a hemorrhage or a placenta previa who would go to a remote clinic, they would call the ambulance and she would climb out of the window and run away. This is what we were facing. So we went to find out why are you running away? Why aren't you coming to the hospital? And for them, the issue was that if they go to the hospital, even if we send the ambulance to get them there, no one's bringing them back. And it's very expensive to get back home. And their assumption was people go to hospitals to die. So I'm going to go, I'm going to die, and then my family is going to have to pay to get my body back. And that's going to set them back by almost a year in income. And what they said to us is, I would rather die at home than take the risk of going to the hospital and leaving the cost to my family. And so we changed what we were doing, but the point was we hadn't listened at the very beginning. We'd missed the trick of really trying to understand what is it that is good from the perspective of the population. In Syria, where during the civil war, we started supporting hospitals, and we went in with our usual ethos of we want to only do cesarean sections when we feel that they are medically appropriate. But we had lots of women and girls coming in asking for cesarean sections, uncomplicated pregnancies, low risk, coming in and saying, I want a cesarean section. And it took time to understand that this was because for them, good maternity care during the civil war meant not going into labour. It meant not having the unpredictability, not having to think about how am I going to navigate a road when there are snipers. So I think really this sort of takes the top of when thinking about what could be good maternity care in a humanitarian crisis. And then lastly, if we're thinking about good maternity care, we also need to think about the future and what does humanitarian landscape look like going forward, and what does it look like for women and girls and their access to care. Both the humanitarian space is being reduced. There's an erosion on the principles that we have, and there is significant loss of funding. We know that official development assistance declined by 27% between 2022 and 2023, and allocations for reproductive health from the US nearly halved. And so, as a result, we're seeing that 4 out of 5 countries are not going to meet their targets for maternal mortality reduction by 2030. And there are certain policies that I don't know how familiar you are with the expanded Mexico City policy, which is the global gag. But this essentially prevents organizations from using their own non-US government funds to provide or advocate for safe abortion care as a condition to receive US global health funds. But the expansion is that it's not for organizations that are only providing safe abortion care. It's also if they were to offer counselling or referrals or direct women and girls to other places that might be able to receive it. And this is also in countries where abortion is legal. And this has had a wide impact, not only on maternal health care, but on many aspects of healthcare. And then there's the Geneva Consensus, also from the US, but is a non-binding political statement which asserts that country governments have no obligation to facilitate abortion care. And this is sort of dressed up, it's a distortion of international agreements, and it's dressed up as being sort of this pro-family, pro-woman policy, but actually what it does is it removes access to contraception, removes access to safe abortion care. Obviously you've heard me mention safe abortion care a lot, even talking about maternal health, but when we look at, humanitarian crises, if I was to take the example of Central African Republic, unsafe abortion, it is not one of the leading causes of maternal death. It is the leading cause of maternal death. Up to 40% of women and girls who die from pregnancy-related complications are dying from unsafe abortion. So restrictions in the ability to have this is gonna take away the ability to respond. So what can we do about it? What can we do looking forward? Well, firstly, we need to really reshift our focus to investing in local providers, local services, and a little bit away from the big international organizations, including my own MSF, but thinking how we can better partner with those within the country, and looking at different funding mechanisms that can be more predictable, more reliable. But this when we think about what's going to be good for the future, we need to think about what are going to be the challenges. So that is, this computer really doesn't like me. Ah, thank you. So yeah, so I'm not sure that I can really tell you in a simple answer what does good look like in a humanitarian crisis, because I think that whatever we, however low we go to say this is the best we can, there's always the risk that we're going to have to go lower. Whatever we say is minimum, we have the risk that we're going to have to dip below it. I think we do the best we can with the resources we've got, and we accept that the situations can often be unpredictable. But I would say that recognizing and responding before at the onset of every crisis is vital. So that, there will be pregnant women and girls, there will be maternal health needs, reproductive health needs in every single crisis. And it's always a surprise to me when I find that other people are surprised that that's the case, when they realize later, like, oh, what about the pregnant women? We know that that's going to be an issue from the beginning. That we apply a gendered lens to all of our crises and think about how they might affect women and girls differently, and how they might affect pregnant women and girls differently to the rest of the population, and learning and improving as we go, exemplarily through the maternal death reviews and responses that we put into place. Knowing that maternity care is part of a bigger picture, it's part of sexual reproductive health and rights, including respectful maternity and newborn care. But overarching for all of it is that we need to be able to listen to the women and girls within the communities that we're responding to. The QR code takes you to Belly Woman if you want to know more about how humanitarian crises can affect pregnant women and girls. And I'm very interested to hear your reflections, and in the time that we have, to have some conversation around what you think might be a way forward to reaching good within humanitarian crises. Yes.
Thank you so much, Benjamin. Wow, what a it was a difficult task I set you in asking what was good, but thank you so much. You covered huge amounts. We've got time for questions. I've got a list of questions, but we should leave it open, and there's some questions online as well. Maybe I can start then, because I get a little bit offended that maternal mortality statistics don't include deaths from violence, or they're called accidental or coincidental deaths. And yet we know very well that women are targeted during wars. There used to be this sort of rather gentleman sort of Geneva Convention, oh, you should look after, but actually that doesn't seem to be the case, that the rule book has been thrown out. And we know how, as part of the aggressive, almost the sort of extreme virility that goes with this, women, especially pregnant women, are targeted. Do you think there's any move to try and change that? Because it would, if you record it, then it's happened. Whereas actually the maternal mortality statistics put that to one side, say, well, it's not really maternal mortality, and it is, and it needs addressing.
Yeah, no, absolutely. So, no, it's a great question.
Do come in so people can hear.
It's a great question. So, you're absolutely right, of course, that accidental. Well, so the way that maternal death is defined, any death of a pregnant woman during pregnancy or in 42 days after, excluding accidental deaths, right? So we discussed this, and we've changed the way that we define. It's a little bit arrogant of us, but we've just changed the way that we define maternal deaths within humanitarian crises for the purposes of when we do these maternal death surveillance response. Right. And what we ask for is that every single pregnant woman or girl who dies is included and every single one, whether they die on the maternity ward, in the medical ward, from a bullet wound, they're all included, they're all reviewed, and we look at how we can respond to them. And only at the very end of that journey, once we've really gone through it in detail, can we say that this does not meet a maternal death that is relevant in this situation. Because like you said, if we see a pattern in maternal mortality, that it's women and girls who are dying on their way to the hospital because that road has got a sniper, or is somewhere that is in an area that's particularly volatile. Well, the fact that women and girls have to use that road to reach that hospital puts them at a more vulnerable position than other people. They have to get to hospital if they've got complications of pregnancy. And part of our response then, by knowing that they're dying using that route, is how can we change that? Can we get the care they need to them? Do we need to look at community-based models for prevention or action on PPH or eclampsia? Do we need to work changing where we're providing care, or working with liaising with different armed groups to make sure that those routes become safer? But if we don't include them, if we don't look at the full picture, then we're going to miss them. And the other thing which I meant to actually mention in the talk, but I didn't, is we do have, we have humanitarian principles that we talk about. So, we talk about the humanitarian setting, but we also talk about humanitarian principles: neutrality, impartiality, independence, and universality. But one of the dilemmas that we have to think about is, how do we apply them within a humanitarian setting on the topic of maternal health? Because there can be times when they come into conflict. And so, for example, if we're working in Afghanistan, we are neutral, we're impartial, therefore we're working with the Taliban. But by delivering maternal health care alongside the Taliban, does that mean that we start giving credibility to the Taliban and their positionality on what does maternal health care look like? And if we don't, then does that take us away from impartiality, and does that take us away from neutrality? Do we continue? Do we leave? If we leave, we know that there's a risk of increased harm to pregnant women and girls. But if we continue, there's a danger that it appears that as a humanitarian aid organization, we condone, allowing a woman to die because their husband doesn't consent to something. So it can be very complicated if we start cherry picking who and what we include.
No, thank you. Questions from the floor? Yes.
Such an important topic. I'm really amazed at what you managed to achieve with FBDSR in that context. I'm not surprised at all that the WHO, that very sort of said they need bother, because it's incredibly complex to set up and sustain. So my question is on that process really. So we know from other work I've been involved in previously, that even if you get the data right in this kind of context, and from the community as well, and piecing it together, and you find out, this is one from the line. It's the next step, right? It's implementing the solutions that need to be put in place, and that's often a critical bottleneck. I just wondered if you could talk a bit about that, and then to follow up on that, has the process continued? Since left in 2021, and then has this rapid approach been replicated elsewhere as well? Because it's clearly something to move beyond the sort of tests that you've done and try and make it work.
Yeah. Can I just repeat that for online, because people may not hear online? So the question is all about the maternal death reviews and whether actually the findings of those can be implemented, because that's often the most complex bit, but also can be sustainable after leaving.
Yeah. No, thanks a lot. Great questions. And I'm always happy to talk about the rapid maternal death reviews because they've been so impactful. So the way that we originally designed it was that the reviews take place rapidly. It's very sort of slick, really what do we need to know? It's not a 12-page document, it's a 1-page document. And once the actions are identified and recorded, they are recorded in a way that they can either be actioned at the time or they can be held for a time when it's possible to action them, so that they can build towards the next strategy, once the situation, the conflict starts to settle down, things that we can't do right now, but we can plan that we're going to do them later. But what we've found is that in all the times that we've used it, which is only 4 so far, Tigray was the first time we used it, but in all the times we've used it, we've been able to implement a significant chunk of those actions because people are making those actions in the moment of the emergency setting. They know what resources they have, they know the challenges they have, and what we're saying is go for the most specific, the smallest action that you can, rather than going for the big ones. But also identifying the leading causes of maternal death, which have, as I said, have been different in each situation, has also meant that they're able to really target in what they're doing. It has been replicated so far 4 times. So first was in Tigray. You're asking, has it continued in Tigray? It's continued. It's still going on. Tigray is most likely to dissolve back into a civil war. And so it's in many ways, the fact that they've been doing this now for several years means that the local team are really adept at using this system. And it's influenced our ongoing strategy. So with the anemia in Tigray, in this period that has not been an acute crisis, we've started looking at things like introduction of IV iron in a humanitarian context, because we're recognizing that we really want to focus on how we can improve this. So it's really developed that part of the strategy. And as far as is it being taken up outside? So in Ethiopia, it's been taken up through the Public Health Institute, which is their Ministry of Health and is now part of their maternal death surveillance national guidance. And on the WHO side, so I'm within the technical working group for MPDSR and WHO, and it's now been presented to them, and there's a lot of interest from their side on, I think everyone recognizes the guidance needs to change, that we should be doing MPDSR in some form in acute crises. And now it's looking at whether that's going to be similar to what we're doing or something different.
Thank you. Yes, Dave.
So like medicine is somehow related. I just want you to talk more about the efforts to sustain some of the efforts of the successes that you gain during these interventions. And I ask that because I've been following these areas for a long time, and it's like an acute and chronic. Tigray is going back to South Sudan, is back in everything. So I want you to talk about what are some of the things that we sustain. There are some capacity building efforts, there are some task shifting efforts, especially knowing that most of these areas are already suffering from a form of structural violence, and their governments really are not very proactive to help those particular.
So the question is about sustainability. Bendra, just come in close to so they can see online.
It's an excellent question. It's also a very challenging one to answer, and I suspect you know that as you've asked it, because as you rightly said, many of the places we're talking about are fragile settings. They are places that have acute crises. They are protracted as well. On top of that, they are severely underdeveloped, and they often fall back into some form of crisis, whether it's another conflict or a famine or an outbreak. So there's a short answer and there's a slightly longer answer. The short answer is yes, we are working on sustainability. There's a lot of task shifting that happens within, I can't say all, but most of the examples that I've given in this talk, there's a lot of task shifting where, whether that's through skilled birth attendants who are being skilled up on how to do procedures that they wouldn't normally do in places that they wouldn't normally do it. So where, like in South Sudan, we don't have access to an operating theatre, but you've got someone with an obstructed labour. What can you do? What can you do as the midwife to either get that baby out or keep that woman alive? And a lot of work happens, and that's very much focused towards the local healthcare workers, the ones who are going to remain with the community for the long term. Something else I was going to mention, it's just slipped my mind. So you mentioned task shifting and local, yeah. So yeah, and the local capacity building. I was going to say, but also with the non-clinical stuff. So for example, with traditional birth attendants, there's a lot of work that goes on, where communities aren't able to reach health facilities at all. So working with them and seeing what capacity can we get within the remit that they can provide, whether that's misoprostol distribution within the community for PPH prevention and treatment, or teaching them how to use garments to be able to buy time, to be able to get people to healthcare facilities, and different education models. But the other part of my answer is, in the end, we are limited by the environment. And as you said, and as I mentioned, like with South Sudan, we can do everything we can for 30 years to try to build capacity, to try to bring about increased resilience. But if acute crises happen and places fall into chaos and people flee and have to move, a lot of that work is going to be undone. And that's outside our control. And that's why, if I was to sum up my answer to the big question, which is what does good look like, I would say it's doing the best you can with the resources you've got and accepting that there are some things which are outside of our control. Because yeah, in the end, this is the world that we live in.
Okay, thank you. We've, I think, got time for two final questions. I want to ask one which is online, which you've clearly got a fan of somebody who loved reading Belly Woman, who found it very inspiring. But the person says it was a privilege to read, but it was mainly talking about Sierra Leone and London. And I wondered if you're writing other things that they can access. Do you run a blog, or have you got a follow-on book, or you've clearly got a great skill, as the awards show?
Well, thank you. I'm not writing another book at the moment, not because I don't want to, but because my role in MSF is very, very, very busy. And every time I think that I might want to sit and start writing, my brain simply says, go away. But yes, I would like to. There's no shortage of important topics to write about, and advocacy that needs to be done in this area. As I said, this is maybe a slightly self-selected audience, but I can tell you that outside of this room, a lot of people do not recognize the importance of sexual and reproductive health and rights and saving the lives of women and girls within humanitarian crises. Yeah, something to be picked up on maybe in the future.
Okay, thank you. And final question. We're running this series about bringing life, and largely it's focused on the UK maternity situation, and things have changed hugely. And people are asking, well, what is good maternity care in the UK? And it strikes me that your overarching principle of listening to women and girls actually is probably a very good overarching principle for us in the UK as well, and something which maybe we haven't done terribly well. But I wondered if there's a lot that you've learned, that because you have this interesting job of working two days for MSF, but you're also labour ward lead in a busy London hospital. What do you bring back from your MSF work to the Whittington that you've learned, which which can help?
Yeah, no, it's a good question. I think that I think it was at the beginning you said that people might confuse that the NHS is a humanitarian segment. I wouldn't go that far. I certainly would say that the NHS is still resource restricted, and I think that not just my experience, but the experience of anyone who's worked in other countries and in other settings can appreciate what it is to try to make the best of what we have. I mean, it's the same answer, really. I think where that was most obvious was during the COVID pandemic, and again, it's something which I write a little bit about in the book, because when COVID happened for the NHS in my maternity that I was working in, there was a lot of confusion, there was a lot of panic, and there was as I'm sure everyone remembers, there was like different guidelines coming from everyone and everywhere in what we should or shouldn't do. And the experiences that I had from working in Ebola outbreaks, cholera outbreaks, other disease outbreaks, sort of gave me the ability to take a step back, work with my teams, and actually go back to listening to women and girls. That's why, so in our unit, we never stopped having birth partners. We were able to look back and say, well, we know that if we want pregnant women and girls, hopefully not too many pregnant girls, but pregnant women and girls in London to continue coming to our department and feeling safe in our department, then we need to do everything we can to make it as appealing as possible. And that means allowing them to have their birth partners with them the whole time. And so we ended up being the only unit.
I think you're the only one in the country, weren't you?
Yeah, we never
kept going throughout.
But that was largely because during Ebola, we made big mistakes with the way that we reached the community and worked with the community. We didn't listen to them. We didn't think about what makes our facilities feel safe during an outbreak that's very scary. And people stopped coming, and we saw worse outcomes in pregnancy. So very different context, but we were able to pull across the lessons.
Brilliant. I think we were only supposed to go till 7, and I could listen to you for hours, as I'm sure we all could, but we should finish. There will be a chance, you'll join us for some drinks afterwards, as everybody is welcome as well. So there'll be a chance to catch up with Benjamin and maybe ask some personal questions.
Not too personal.
Well, okay. Ask some questions too personally, I should have said. Apologies. It only goes for me to really say thank you very much. Thank you for coming. But maybe thank you also to MSF as an organisation. It's a hugely impressive organisation, and it's as it were, my favourite charity, and I would urge anyone to contribute to their excellent work. And I think sometimes you worry about charity giving, and you think, is it going to? And really, your talk today has only reassured me completely that MSF is actually following its way of providing pragmatic, robust, woman-focused care or victim-focused care, which is so important. So thank you very much for that. We do have a little something which we give to our speakers, which we're a small medal as a token of our appreciation. Our next meeting this was number 10. We've got 20 lectures in this series. This is number 10, and number 11 is Abby Merrill, who's a senior lecturer here in Liverpool, and whose particular passion is antenatal education. And she's talking about antenatal education classes. Are they the key to unlock the maternity crisis? Again, this is a listening, focusing on this, listening to women and girls. So that's in 2.5 weeks. It's on a Monday, so it's on Monday, not on a Thursday. Most of them are on Thursday. That's on a Monday, so don't get muddled up. It's the 23rd of February. The programme is available. You'll see programmes outside. Do pick them up. It's got details inside of all the lectures which are coming up. They're also, of course, available online, and it's worthwhile just checking before you arrive online, because that's got the most up to date. If you click on the links online for future, just go through them, click on the links that you're interested in, and it'll go into your calendar, and reminders will come up. Membership, everyone's welcome to be a member here at LMI. In fact, for the medical students, it's free membership, which is fantastic. For most other people, it's about £50 a year. So you're very welcome to join us at LMI. Consultants pay a little bit more, which is probably only right. But for most people, it's £50 a year. We normally have refreshments outside. It's normally members only, but in the spirit of this, we've opened it up to everyone tonight. So please come and join us for a glass of wine outside and a few nibbles round in the library, just round to the right. Stop off at the MSF stall. You've got some information outside. Thank you very much for coming. And so it only ends for me to say thank you very much, Benjamin. Very much appreciated. Thank you so much for coming all this way. And we look forward to chatting to you afterwards.
Thanks a lot.
Thanks so much.